Hey everyone, we're doing a quick walkthrough of the kidney function today. In this video I'll be teaching you a little bit about how kidneys filter blood, reabsorb solutes in water, regulate blood pressure, and produce either concentrated or dilute urine. We'll cover several interconnected systems and cellular mechanisms. Let's get started. Alright, we're going to start with a short overview of the nephron. The nephron is a functional unit of the kidney. And each kidney, so the body has two kidneys, and each kidney contains about 1.2 million nephrons. And each nephron is responsible for filtering plasma and processing the filtrate into the urine. And the blood of the body, the cardiac output, about 20% of it goes to the kidney. So every time your heart beats, the blood that's pushed out, 20% is going to go straight to the kidney. Alright, and now a little bit on filtration within the renal corpuscle. And here, filtration begins in the renal corpuscle where blood enters via the afferent arteriole. Blood will come in and it will travel through the glomerular capillaries and then exit via efferent arteriole down through here. And this is where filtration is going to occur. And so filtration membrane right here between your capsule and the capillaries has three different layers. It starts from superficial to deep. The fenestrated endothelium, which is with the capillaries and it blocks blood cells from leaving the capillaries. You have the basement membrane in between, and this blocks large proteins from leaving. And then the podocytes, which is more towards the Bowman's capsule, which forms slit diaphragms that limit filtration based on size and charge. And so filtration is a pressure-driven process. And so the NFP, or net filtration pressure, is about 10 mmHg, millimeters of mercury, as calculated through three different processes, three different forces. So we have the glomerular hydrostatic pressure, and that's a pressure from your glomerular capillaries pushing out from your blood pressure. Then you have your capsular hydrostatic pressure, and that's from your capsule, and that's pushing back in. And then you have your BCOP, or blood colloid osmotic pressure, and that's the proteins within the blood that are absorbing back in. So if it's about 55 from the glomerular hydrostatic pressure, 55 millimeters of mercury, and then you subtract the other two from that amount because the other two forces are going back into the capillaries, that will total out to be about 10 millimeters of mercury of pressure going out of the glomerular capillaries. Now a little bit more on the efferent control of filtration. We call this GFR regulation, which also stands for glomerular filtration rate. And so this is the volume of plasma filtered per minute through the kidneys. And typically that's about 125 milliliters a minute. To maintain this steady GFR rate, the kidneys use an autoregulatory system, or autoregulation. And so there's the myogenic mechanism, which is like the muscular mechanism of the smooth muscle of the arterioles. And so the stretch of the afferent going into an afferent arteriole causes it to constrict, which will lower blood pressure, causing filtration to slow down. And then you have the tubuloglomerular feedback. And so the macula densa cells detect sodium levels and release nitric oxide, or adenosine, which adjusts different tonnage of the smooth muscle as well. And so both of these will help keep that consistent GFR around 125 milliliters a minute, so we're not over-filtrating or under-filtrating. Now a little bit on the RAAS pathway, or the renin-angiotensinogen angiotensin 1, ACE, angiotensin 2, and aldosterone pathway, or more focus on just the renin-angiotensin aldosterone system. And so in this system, or this pathway, if systemic blood pressure drops, or your GFR, which is basically connecting back to your blood pressure, your RAAS or your ROS system kicks in. So renin is released from your juxtaglomerular cells, and these cells will convert angiotensinogen, which is a zymogen, to angiotensin 1. And then ACE will also convert the angiotensin 2, which will constrict efferent arterioles and stimulate aldosterone and ADH. And through this will increase the sodium along with the water reabsorption, which will raise your blood pressure. So ultimately, as your blood pressure drops, your GFR drops, which will then increase renin enzyme, which will, through a couple pathways, inhibit, or ACE will, so your ACE enzyme will activate angiotensin, which will then allow release of sodium into the bloodstream, which will then pull along water with it, increasing your blood pressure. Alright, now a little bit on tubular reabsorption. And so reabsorption occurs through a good portion of your tubules, but a good example to look at is the proximal convoluted tubule. And within the proximal tubule, the majority of filtered solutes and water will be reabsorbed here. And so about 70% of sodium, chloride, and potassium and water will be reabsorbed here, and 100% of glucose, unless you are diabetic, is reabsorbed here, as well as amino acids under normal conditions. And so here we have the sodium-potassium ATPase pumps that pump sodium into the interstitium, creating a gradient. So that's primary active transport. And then through secondary active transport, we're going to have these symporters, which pump sodium back in. As the sodium was pumped out, it creates that gradient. Sodium is pumped back in with lactate or amino acids or glucose, and then you have an antiporter with sodium coming in and hydrogen leaving, and this is what allows the movement of reabsorption of these molecules. And so water will also follow sodium osmotically through these aquaporins that we have here, and that's how water will be reabsorbed. And then also you have your hydrogen, which is pumped out as it is removed from CO2 and H2O as it combines to make bicarbonate and hydrogen. And then when it pumps out, it recombines with bicarbonate to make water and carbon dioxide. And then that carbon dioxide can flow freely back into the cell, and the process continues. And then you have a chloride channel antiporter, which pumps the bicarbonate back into the blood. So blood's on the right side, within the tubules on the left side, and we're pulling out the majority of these solvents. And then there's something called solvent drag. That's where calcium and potassium follow water as it moves across the gradient. Now a little bit about renal threshold and saturation. And so with renal threshold and saturation, reabsorption will have its limits, and specifically for something like glucose, the transporters will be saturated around 200 milligrams per deciliter. And so once this is exceeded, glucose will appear in the urine, and this is known as glucosuria. or a hallmark of diabetes. And so as you have too much, so technically as insulin is produced, it helps the absorption of glucose into the cells. But when you become insulin resistant, the glucose will not be absorbed in the cells, causing a buildup of glucose in the blood and causing the blood to then be filtered. And since the body wants to reabsorb as much glucose as possible, it will saturate those pathways to 200, at maxing out about 200 milligrams per deciliter. And so we know that someone has diabetes or is pre-diabetic or something along those lines when they are excreting glucose in the urine. Now a little bit about the loop of Henle and the medullary gradient. And so the loop of Henle is a critical part of concentrating urine. And so it's this loop that goes down here, and we've got both the descending and ascending tubule here. And so within the descending tubule, it is permeable to water, but not solutes. And so this pulls out only water, and it causes the liquid within the tubule to become very concentrated, or the filtrate will become very concentrated. And on the ascending tubule, it will pump out a lot of sodium chloride, and it is impermeable to water. And so filtrate will become more dilute. And so depending on your body's needs, it will either pump out more water or pump back in more solute. And this will set up your this is a countercurrent system. And this sets up the medullary gradient. And so in cases of the deeper loop here, the gradient can reach up to 1200 milliosmoles. A little bit about the vasorecta. The vasorecta will help preserve the gradient. And so on the way down, as water exits and salt enters, and then on the way up, water re-enters and salt will leave. So the net effect is that solutes will stay in the medulla and water will be recovered. Now a little bit about the collecting duct and hormonal regulation. And so with the collecting duct, this is where the body will fine-tune the urine concentration. And so with ADH, which is a vasopressin, it will bind to the V2 receptors, which will trigger the aquaporin 2 insertion, which allows water to come in, or if it doesn't activate, it will keep water out. So when we're dehydrated, it will allow water reabsorption to pass through the medulla. And then aldosterone acts on the principal cells. And so principal cells will increase sodium reabsorption and potassium secretion. And so it will stimulate more sodium-potassium pumps and epithelial sodium channels. And finally, we are going to talk about clearance and estimating GFR. Clearance uses the equation of clearance equals the concentration of a solute in urine times the volume that passes through divided by the concentration of the solute in the plasma. And so clearance is the volume of plasma cleared of a substance per minute. And if the substance is freely filtered and neither reabsorbed nor secreted, like inulin or creatinine, the clearance will equal the GFR, but that's not the case for most things that are passing through the kidney. But that sets a baseline, the inulin and creatinine, and then off of that we can estimate GFRs for other things. And so creatinine is the most commonly used clinical thing to see how well our kidneys are working based off of this clearance, which equals over to the GFR.